Welcome. I would like to welcome everyone joining this workshop. Thank you for your time. My name is Ambrish. I'm a PhD research scholar at Menzies Institute based at Hobart, Australia. I work primarily in health economics and epidemiology domain in the disease area of osteoarthritis and musculoskeletal disease. Today, we have Dr. Lidia Engel here with us, who will be presenting on the application of checklist and reporting standards in health economic evaluation. Dr. Lidia is a postdoctoral research fellow at the Dakin Health Economics, based at the Institute for Health Transformation. She holds a PhD from Simon Fraser University, Canada, an MSc degree in health science from Maastricht University, Netherlands, and she has a bachelor's degree in health economics from the University of Cologne, Germany. She is a trained health economist and has a great interest in methodological approaches when assessing the cost effectiveness of different healthcare intervention. She specializes in the measurement and valuation of quality of life and informal care, as well as the economics of mental health and aging. She has advanced skill in undertaking the trial-based and model-based economic evaluation, systematic literature review, psychometric validation studies, and qualitative research. In her current role at the Daikin Health Economics, Dr. Lydia is leading the stream of economics of aging and dementia, undertaking a broad program of economic research with an aim to improve quality of life and care for older adults and their informal cares. So with this, I welcome Dr. Lydia to take ahead the session. Thank you for being here.
Thank you so much for the introduction. I think I'm going to start my presentation with the acknowledgement of country. So as we gather for this meeting, physically dispersed and virtually constructed, let us take a moment to reflect on the meaning of place, and in doing so, recognize the various traditional lands on which we do our business today. We acknowledge the elders, past, present, and emerging of all the land we work and live on, and their ancestral spirits with gratitude and respect, and to recognize their continuing connection to land, water, and community. I also pay my respect to other Aboriginal and Torres Strait Islander people present. Now, before I tell you more about the use and misuse of checklists, I wanted to briefly tell you more about myself, and I appreciate Ambrish gave already a bit of an introduction. So I'm currently a postdoctoral research fellow at Deakin Health Economics, and prior coming to Deakin, as Ambrish said, I completed my bachelor in Germany, my master's in health science at Maastricht University, and my PhD at Simon Fraser University in Canada. Now, what's of interest maybe to this group is that during my time in the Netherlands, I actually co-founded the Maastricht ISPOR student chapter, which still exists up until now. And I also contributed to the UBC ISPOR student chapter in Vancouver during my PhD studies. I'm currently a Euroqual member, hold a membership officer role with AHAS, and sit on the Scientific Advisory Committee of Ending Loneliness Together. Now, I have great interest in outcome measurement, economic evaluation, mental health, aging and dementia, disability, loneliness, and informal care. And more specifically, I'm very interested in the methodological approaches for economic analysis, which includes how we measure and value costs and benefits, and also the way we undertake economic evaluations, including reviews of economic evaluation studies and the use of checklists. Now, before I tell you more about the research I'm doing around checklists, I actually want to hear from you and hear whether you have previously used any checklist. So I've prepared for today's talk a live vote for us, and ask you now to please go to menti.com and enter the code that's shown here in red to actually start the voting. So you will see a list of 6 checklists, and you can select multiple checklists. And this really just gives me an understanding of who it is in the audience today and whether or not you have been using previously any sort of checklists. And I might gonna just quickly stop my presentation and go to the, people already starting voting. Fantastic. Okay. So the live vote is ongoing. I guess you can see it. Okay, so it looks like cheers is right now the most commonly one used, followed by Drummond, BMJ in Czech, 9%, and a few people in the audience have not used a checklist before. So that's very valuable information. Okay, even the other ones, QHAS and Philips. Okay, that's really good to see that people have had some sort of exposure to various checklists, although a few haven't used checklists before. So I hope you will find in this talk particularly interesting. Fantastic. Thank you so much. I'm going to return back now to my presentation. Okay, now why are health economists using checklists? Well, we know that economic evaluation studies are heterogeneous with respect to purposes, conceptual and measurement issues, and the value judgments leading to problems with comparability and suboptimal delivery of care. Now, the increase in economic evaluations being undertaken has led to an increase in systematic reviews of economic evaluations. And as a consequence, quality assessment checklists have been developed to evaluate the quality of published economic evaluations. So there are different quality appraisal checklists available to standardize the assessment of economic evaluations. And importantly, this can refer to both the quality or completeness of an economic evaluation. Generally, checklists contain a list of criteria or items against which a reviewer assesses the study. So I have listed here some of the commonly used checklists, which, as you can see, differ with respect to the number of items and their response options, where some checklists have only a yes/no response, and others include not clear or not appropriate options. So compared to other checklists, I also need to point out that the QHAS is the only one that has a weighted scoring for quality assessment, where some items in the checklist receive greater weight compared to others. Now you can also see that some checklists were specifically designed for trial-based economic evaluation, such as the Czech checklist, or for model-based economic evaluation, such as the Philips checklist, whereas others may be applied to both. Importantly also is that some checklists were developed to critically appraise the quality of economic evaluation, whereas others, such as the CHIAS checklist, was developed to judge the reporting quality. So whether authors of the economic evaluation study have reported all important aspects of their study. Now in 2019, there was this review paper that was published in Value in Health, looking at which checklists are most commonly used. And you can see in the right table that the BMJ was the most frequently used checklist, followed by the Czech, the Philips, CHIAS, and Drummond. Now, interestingly, is also the number of modified checklists used, which indicates that people may have found the checklist in its current form not suitable and saw the need for adjustment. In a number of studies, you see that multiple checklists were used, especially in combination with the Philips checklist, which is more suitable for modeling. Again, this indicates that there is a lack of one gold standard checklist, and that sometimes multiple checklists are needed, which of course is very time consuming if you have many studies included in your review. The same review also looked at how reviewers present their findings. So this review found that about 58% of the studies presented the results of their quality assessment as a quantitative score, which is quite interesting, as most of the checklists have only a yes/no response and only allow for a qualitative assessment. Now, when the QS checklist was removed from these, given that the QS checklist intends reviewers to score studies, still 49% of the studies provided actually a quantitative score. And we can see here that quality assessments were presented in 5 ways. An individual item score, so for example, item 1 for study 1 was completed. Study scores with and without quality rankings, such as good or poor statements, or like study 1 scored 9 out of 10. Then global item scores, where, for example, the average score for checklist item was 75% or 100%, and domain-specific scores. So, for example, regarding sensitivity analysis, in 80% of the studies, this was completed. Now, reviews, where reviews scored economic relations and provided a threshold that indicated high quality, the review also found that the threshold varied. So the minimum reported cutoff for an evaluation to be considered high quality was 63%, and the maximum was 94%. So we see there's still a lot of arbitrary thresholds that are applied. So generally, the current problem that we have with existing checklists is that most checklists are not comprehensive. So we have vertical comprehensiveness where individual items are not comprehensive enough, or you can think of a horizontal comprehensiveness where there are important criteria which are not included in the checklist at all. So it seems that there is currently no one-size-fits-all approach, as we know that some checklists are better for trial-based economic evaluations and others are better for model-based economic evaluations, which often leads to combining multiple checklists or modifying existing checklists. There are issues with the scoring of checklists where sometimes results are presented in a qualitative way and sometimes people attempt to derive a summary score, and then, as I said, arbitrary scores or thresholds are used for classifying quality. Now, this ultimately suggests that further guidance with existing checklists is needed to improve clarity around the scoring of checklists. And additionally, we know that there is a high level of subjectivity involved when applying checklists. So everyone approaches checklists differently, and therefore, ideally, each paper should be assessed by at least 2 reviewers. Finally, we also know that the years of experience of the reviewers and their experience in certain health areas may influence their responses. So this could, of course, also impact the level of agreement between reviewers, but little research has been done in this area. Now, given all that, we decided actually to do ourselves some more research in that area. So at Deakin Health Economics, we are involved in numerous economic evaluation studies and often also undertake reviews of economic evaluation studies. And back in 2019, we had a training seminar where we actually discussed how these checklists should be completed, which checklist to use in what circumstances, and whether there has been any evidence in terms of their validity. Now, we realized that there was limited evidence out there and decided to undertake our own small study in which actually some of you may have participated. And if that is the case, I would like to express again my gratitude for your time and contribution to this study. So the study was funded by the School of Health and Social Development at Deakin University. And the aim of the study was to validate 6 of the most commonly used checklists using a mixed method study design. And we undertook 3 sub-studies to answer our research questions. So in study 1, a quantitative comparison of 6 checklists was undertaken. And this was done via an online survey, which was completed by 26 health economists residing in Australia. And each participant was asked to complete 6 checklists to an economic evaluation study, which was either a trial-based or model-based economic evaluation. So we ensured that the same study was used by at least 2 participants in order to assess the intra-class correlation and to calculate the kappa index. And participants were also asked to rank each of the checklists they have used according to their perceived relevance. Now, given that we recruited health economists with different levels of experience working in various health areas, which could, as I just said, influence their responses, In study 2, we asked 2 of our junior health economists at Deakin to apply the 6 checklists to 11 studies. So both of them have completed their Master of Health Economics at Deakin and have been working in the area of mental health. And so the aim of this study was to get a better understanding of what drives potential differences in completing these checklists when accounting for such personal factors like years of experience. Additionally, we undertook qualitative think aloud interviews to get a better understanding of how health economists complete these checklists. And while data analysis is still ongoing with all 3 of these studies, I will share some of the early insights from study 3 with you today. So we recruited for this qualitative study 16 participants via postings on the AHAS website and Twitter, as well as word of mouth recruitment. And while initially only health economists residing in Australia were eligible, we opened up the recruitment also then to international health economists to increase the number of participants. And you can see that we recruited in total of 4 international health economists as well. Now, although we tried to purposefully sample the participants based on years of health economics experience, the majority of our participants had 5 or more years of experience. However, we were still able to recruit some junior health economists and 1 person with 2 to 5 years of experience. The majority were female, aged 41 years on average, and everyone had experience in undertaking economic evaluations, as well as using checklists, except for 1 person. So we picked 8 economic evaluation papers, which were either trial-based or model-based, and either of good or bad quality based on our own assessment. And so we varied the allocation of checklists to ensure good coverage, but also keeping in mind that some are more lengthier than others, and we needed to ensure feasibility because each participant was asked to apply 2 checklists during a 1.5-hour interview. And you can see that overall, each checklist was discussed by at least 4 participants with a maximum of 6. So we undertook qualitative think aloud interviews either in person or via Zoom. Participants were sent the economic evaluation study 1 week in advance so they could familiarize themselves with it. And at the day of the interview, 2 checklists were presented. When interviews were undertaken via Zoom, the interviewer then just shared the screen with the participant, showing the checklist. And the reason for that was that we wanted to ensure that we capture the immediate thoughts participants have about the checklists when applying them directly to the study. So during the interview, participants were asked to think aloud any thoughts in their mind as they applied the checklist to the economic evaluation study. And as I said, the interviews lasted on average 1.5 hours. They were audio recorded and then transcribed verbatim. Qualitative data were then imported into in vivo and a thematic analysis was undertaken. So the thematic analysis was based on the theoretical framework around the psychological processes involved in answering questions, which differentiates between comprehension, so the understanding of the question, retrieval, referring to whether or not participant could retrieve appropriate information from memory, judgment, so how the recalled information should be used to answer, and finally response, so referring to the formatting information into a valid response. Now, as I said, although we are still finalizing the data analysis, I can share some of the preliminary findings with you today. So when completing quality appraisal checklists, health economists express concerns about their understanding of certain items or particular words in the checklist. So for example, item 10.1 in the Drummond checklist asks, were the conclusions of the analysis based on some overall index or ratio of cost to consequences? If so, was the index interpreted intelligently or in mechanistic fashion? And one of the study participants said, I don't know if it's intelligently or not. They give the conclusion based on what they found, yeah, but what does it mean intelligently interpreted? Participants also identified some ambiguous or double-barreled items. So ambiguous questions refer to questions in which there is more than a single way to interpret it, and double-barreled items refer to questions that touch upon more than one issue, yet only allow for one answer. So for example, question 8 in the QHAS touches upon the time horizon and the discount rate in one question, yet only a yes/no response can be given. Or in the Drummond checklist, question 1.3 asks, was a perspective for the analysis stated, and was the study placed in a particular decision-making context, where one participant the first question with yes and the second with no. So participants, however, were also concerned how the answers would be interpreted by someone else. So where one participant stated, but the thing here is when you answer cannot tell, when someone else reads it, they cannot really say if this cannot tell is for the first question or for the second question. And this applies to all those questions with the two parts. Finally, participants sometimes could not see the difference between questions and stated that in their point of view, they are referring to the same thing. Or they found that some questions, or rather the direction of response option, confusing. So for example, question 2.1 in the Drummond checklist asked if there were any relevant alternatives omitted, where no means actually a good thing, but in the rest of the questionnaire, no means a negative thing. So it was a bit confusing because the direction changed for some of the items. The second theme was retrieval, referring to the step of retrieving appropriate information from memory. So respondents discussed their personal expectations from the paper in order to meet certain criteria based on their own methods used and their own experience. However, in some circumstances, respondents could not connect the question to relevant information, which was often driven by unfamiliarity with certain terms or concepts. Sometimes respondents were unable to retrieve information due to lack of expertise in the health area. So for example, one participant stated, this one, I could benefit if I have a clinical knowledge about what's an appropriate outcome for this one. But as long as the outcomes are justified, then I would say that's identified. Some questions in the checklist also assume prior knowledge. So this, for example, one participant said, so this question relies on you knowing the different models that are available, because this is a Markov model and I've worked with Markov models before, hence I'm just like, yeah, that's easy. Yes, that's appropriate. Respondents expressed the need to search for additional literature in order to answer the question. So someone said, so for this one, maybe if you spend a bit more time looking into it, search about it, not just reading the papers. If the relevant information could not be retrieved from memory, respondents also discussed certain response strategies in order to answer the question. Now, when it comes to the judgment process, so correctly judging how recalled information should be used to answer the question, the interviews revealed quite interesting information. So sometimes respondents ignored the fact that the information needed could not be retrieved from the paper, or they reinterpreted information from the paper to fit the criteria in the checklist. To correctly judge the quality, participants made sometimes reference to existing guidelines in order, for example, to judge whether an appropriate perspective was adopted in a study or not. In some cases, respondents' judgment was driven by the author's statement in the paper, the overall perceived quality of the paper, or based on assumptions where, for example, participants said that they assumed that discounting was not applied because the study only had a one-year time horizon period, for example. Now, during the interview, respondents also acknowledged their subjective judgment and personal attitudes, and they felt that needed to be considered. So respondents felt the need to justify their understanding of something, while at the same time acknowledging that others may interpret the question or content differently. So some also commented on their general behavior or attitude being more lenient or kind compared to maybe other reviewers. In some situations, respondents did not necessarily agree with the checklist and perceived that the item was irrelevant to judge the quality of the paper. Now, formatting the information into a valid response was not always easy for study participants. So in some circumstances, respondents would answer the question with yes, although they were not certain about it, or in other situations, they would answer with no, and they were still uncertain. So this was particularly an issue for checklists that forced reviewers to answer either yes or no, and not giving the option for unclear or cannot tell. Sometimes respondents selected the not appropriate option, but could not quite tell why, or used the not clear, cannot tell response option if they were uncertain, especially for double-barreled questions where in the first part they would have answered yes, and in the second part no. So overall, they judged it as cannot tell. Interestingly was also that respondents talked about re-evaluating their responses. So for example, after discussing and comparing their responses with their colleagues, they said that they may change their mind and change their responses accordingly. Now, we are currently also extracting information in a systematic way with regard to overall comments made by respondents. So this relates to the changes they propose, the applicability of the checklist for trial-based and model-based economic evaluation, the perceived purpose of the checklist, so whether the checklist should be used for judging the reporting standards or quality of the economic evaluation, then comments with regard to the length of the checklist and their perceived practicality, the clarity of instructions and overall understanding of the checklist, and whether respondents thought that the checklist was comprehensive and relevant. Now, just to wrap up my presentation, I guess the take-home message from my presentation is to be aware of the current issues around checklists. So if you have ever queried what the specific question in a checklist was about, I hope that some of the results from the qualitative analysis that I've shown you today reassured you that you are not alone. So many health economists experience problems when applying these checklists. Now, in terms of what can we do about it and the next steps, I guess keep an eye on the findings from our study, especially when we have analyzed the quantitative data, which will hopefully provide some evidence around the validity of these existing checklists. In the meantime, I guess you should familiarize yourself with different checklists, discuss those with your team, check whether all questions are understood by everyone in the same way, and select the most appropriate checklist when you undertake a review. Now, regardless of which checklist is used, there will always remain a certain level of uncertainty with regard to subjectivity in reviewers' personal attitudes and experiences. But I guess some of these issues can be avoided by having really deep discussions within the team around the use of checklists and how questions should be answered in different circumstances. And as a final point, I should maybe also mention that only last month or so, an ISPOR practices task force report was published in Value in Health, where they developed the CICERO checklist, which stands for the Criteria for Cost Effectiveness Review Outcomes. So it includes 13 questions to consider when evaluating the quality of reporting, conduct, and risk of bias in systematic reviews with cost and cost effectiveness outcomes. So rather than a checklist to judge the quality of economic evaluations, it's a checklist to judge the quality of the review that summarizes economic evaluation evidence. All right, and with that in mind, I would like to thank you all for your attention. And if you have any thoughts or questions, please get in touch with me. Thank you so much.
Thank you, Dr. Lidia, for the wonderful presentation. I really enjoyed it a lot, and we
Thank you.
do have got a few questions to
Great.
start with. So this is a question from Tan, where he's asking about regarding the weighting in this quality assessment checklist, and assuming that some of the parameters may be more critical or should have or may have more weight in terms of quality. Are there any
Yeah.
consideration regarding this in these different checklists?
Yeah, so as pointed out in the earlier slide, so at the moment, only the QHAS checklist has this incorporated weighting scoring. So where some items receive greater weight because they are more relevant. And this came from memory. I think it was a Delphi study that was undertaken with health economists and other experts to basically come up with these sorts of weights, because we realized there are, of course, a number of critical aspects you need to look out when you do undertake a critical appraisal of an economic relation. But as correctly pointed out, some aspects are more critical than others. So, and at the moment, only the QHAS checklist really has these weighting, the weights applied, whereas remaining existing checklists, they don't have it.
Great, thank you. And I've got a couple of questions from my end as well. And before I proceed with those questions, I would again remind participants, please feel free to put your questions in the chat box. So one of the things which I was thinking about, is there a minimum kind of experience or expertise which is expected from the researchers who are going to assess the quality? Because this is one of the most important part of a health economic systematic review. So what are your suggestions or what are your points onto that?
Yeah, that's a really good question. And look, this is something we wanted to particularly explore in our little study that we undertake at Deakin Health Economics, because we know oftentimes even junior or someone who's doing a PhD, or even this could be part of a master's project, needs potentially do a review and is always asked to apply these checklists. And of course, without any practical experiences of undertaking economic relation themselves, it might be very challenging to actually use these checklists to judge the quality of an economic evaluation. So that's something we are also trying to explore, but not only the level of experience, health economics experience. I think what came out from the qualitative interviews is also the relevance, having a good understanding of the clinical area, of the health area. Because if you want to take, I don't know, a literature review within the context of mental health, for example, you should have a good understanding, okay, what are the potential cost drivers in mental health? Did the study capture those or not? But of course, in order to make these critical judgments, you need to have a good understanding of the mental health area. Of course, we make the assumption that, you know, this will get discussed and there will always be involvement of clinical experts potentially, but I think in reality, oftentimes people who undertake reviews are sometimes left on their own, and need to, that's also something that came up from our qualitative interviews. They actually need to do more searching themselves. So and just applying a checklist to one study can maybe take up to a day, because, you know, the person has to search for additional information to actually be able to make an appropriate judgment.
Yeah, I completely agree. I was just thinking, are there any ready reckoner guidance provided into any of these checklists along with the questions posed, that, okay, this is the question and maybe these are the points which you can which can help you to assess these elements?
They are. So I'm just now pointing out maybe, for example, the Phillips checklist, which is particularly used to judge the quality of model-based economic relations. So it has really some hints what you should look for. Interestingly, though, is that when participants used the checklist, they found it very lengthy, too many words. I mean, it's kind of, I think there needs to be a nice balance. So you want to provide sufficient hints for the reviewers to make an appropriate judgment without, without providing too many things, because then the reviewer spends actually a lot of time reading the questions of the checklist rather than applying it. So, but there are some of the checklists, they do provide some guidelines in terms of what to look out for, whereas others they don't, which is a limitation. And then that's also, that potentially leads that some reviewers interpret the question in a completely different way than others because of the lack of these additional guidelines.
Thank you for shedding light onto that. So we've got one more question from Tan, where so he was wondering whether there are any consideration to report the Cohen's kappa for the agreement between agreement using the checklist, maybe between the reviewers.
I'm only aware of one study. The name from the first author escaped my mind now. But so before we started with our own project, we had a look at literature, and I think we only came across one empirical study that looked at the level of agreement between reviewers applying these checklists. So there is not much evidence out there, but that's the reason why we decided to do our own study, and we will definitely look at the level of agreement in two studies, so where we recruited 26 health economists in Australia, but also in our study too, where we have 2 junior health economists with the same level of experience and background, and just to see how the level of agreement is when we account for these personal aspects such as years of experiences, etc.
Great, that would really be very interesting to know what would be the outcome of such a study.
Keep an eye on the results. So we are just about to analyze the data and should hopefully submit something later this year to a journal.
Sure. Yeah. So Tan has just made a comment that so he's saying that it is kind of moving forward as a part of transparency thing in this
absolutely
context,
absolutely. I think we have to recognize that there are problems with existing checklists, and yet especially decision makers really look at the results. And so I think we need to be, as Tan pointed out, be transparent how health economists complete them and the potential struggles that even health economists have, and just to be very transparent about it. And I guess some of the problems can be avoided by improving certain aspects of the checklist, but I guess other aspects such as level of experience or having a good knowledge of the health area, that remains regardless which checklist you're using. So that's something I think we need to educate people in general in terms of how we should use these checklists and what sort of training should be provided.
Yeah, completely agree with those points. Yeah, and just one more quick question. Maybe this is kind of the last question from my end. Sometime what I've observed is sometimes reviewers actually asked for 2 checklists to be used in one systematic review of health economic analysis. One of the experience which I had in one of my earlier study that we already has used and reported CHEERS outcome assessing and the primary studies on CHEERS, but then reviewer were interested to know about the extended Drummond checklist, the 24 item checklist. And so initially my sort of take was that CHEERS has already been there, but then the point was that CHEERS is kind of a reporting only, where Drummond is more of a quality aspect. So in the end, I had to use both in the paper. So what are your thoughts onto it?
Exactly. And look, I mean, I've seen reviews where they use the CHEERS checklist to actually judge the quality. But you are absolutely right. The CHEERS checklist was mainly developed to ensure that health economists report all aspects of the economic evaluation. So that's more about reporting quality. I guess I think there is no perfect checklist, and there will always be a need to potentially combine checklists, as the review also has found. Especially if you have a checklist that was designed for trial-based economic evaluations, but then in your review you have a bunch of model-based economic evaluations. So you just don't want to miss important critical aspects that are only applicable to models. And so I think there will always be a need to potentially use multiple checklists, but ideally, to make things easier to improve comparability, why can't we have just one checklist that's applicable to both economic and trial-based, model-based? Ideally has also some weights incorporated, a nice scoring, a standardized threshold, so you can actually say, okay, this study scored 70%, so that's high quality, whatever. I think this will make life so much easier for health economists, but also for decision makers to be able to make comparisons. At the moment, it's a bit messy, and different checklists cover different items, and so we are kind of comparing apples with oranges to a certain extent.
Yeah, you're right. Great. So we are kind of around at the end of this session. So again, thanks a lot, Dr. Lydia, for your wonderful presentation and your thoughts onto it. And I also thank all the attendees for their time and participation. And at the end of today's symposium, I would again remind that we'll be sending an evaluation form, which we would request and appreciate if you kindly fill that out and share that with us. So now we'll go for a lunch break and return at 12:50 for the workshop 3. So thank you everyone for your time and interest.
Thanks. Bye-bye.
Thanks.